to today's webinar hosted by the Colorado Cancer Screening Program in partnership with the University of Colorado Cancer Center's Rady Center for Esophageal and Gastric Center as a Center of Excellence. This webinar is the second session of our 2026 GI Cancer webinar series and is focused on provider and patient perspectives of colorectal cancer screening, early detection, and treatment. We're thrilled that you all can join us today as it's Colorectal Cancer Awareness Month, and that's why we're all wearing blue today. I'm Elsa Staples, the Senior Program Manager for CCSP. I'm also joined by Joe Henning, who's CCSP's Senior Coordinator, and I'll be formally introducing our speakers in just a moment. But before we get started, just want to cover a few housekeeping items. So first, we always love to see who's joining us. So if you could go ahead and share in the chat your name, role and organization, where you're joining us from today, and also any specific efforts or activities you've been engaging in for Colorectal Cancer Awareness Month. Would love to hear what's happening. So you're all currently muted, but as we go through the webinar, feel free to add questions or comments for the speakers in the chat. We'll be monitoring it and make sure to address them during the Q&A. And there might also be an opportunity to come off mute to ask questions near the end. This webinar is also being recorded, and the slides and recording will be shared in a follow-up email that will be going out next week. And also the materials will be added to CCSP's website. We'll also be sending out an evaluation in the follow-up email and put the link in the chat near the end. And lastly, I'd like to just quickly plug the two additional events that CCSP has coming up, and Joe will drop links for those in the chat. So first, on April 1st from 11 a.m. to 1:45 p.m., CCSP will be hosting our 2026 virtual convening for all of our participating clinics, as well as any external partners that would like to join. And during that, we'll be having a showcase of colorectal cancer screening strategies being implemented by CCSP clinics around the state, as well as a discussion of hot topics in colorectal cancer screening and early detection, building off today's webinar and featuring a panel of awesome guest experts. And then secondly, on April 23rd from 12 to 1 p.m. will be our third and final session of the GI webinar series focused on esophageal cancer. So we'll include those in the chat and the follow-up email. But now, without further ado, I'm really excited to introduce our speakers for today. So first up, we'll have Dr. Sarah Safady, who's an assistant professor in the Division of Gastroenterology and Hepatology at the CU Anschutz School of Medicine and is a practicing gastroenterologist. She's been a wonderful champion for colorectal cancer screening and is going to share some key information about medical guidelines and best practices. And then we'll also be hearing from Michael Holtz, who's a stage 3B rectal cancer survivor and a patient advocate. And some of his roles include chairman of the board of directors for Man Up to Cancer and as a research advocate for Fight Colorectal Cancer. So we're very appreciative to have him join to share about his personal cancer journey and some perspectives on how healthcare professionals can support patients throughout the cancer care continuum. So I'll turn it over to you, Dr. Safady, to pull up your slides and get started. So thank you both for being here.
Thank you so much, Elsa. And thank you all for being here. Let me start with sharing my slides. Can you all see them? Perfect. So thank you to the organizers for the opportunity to speak today. As Elsa mentioned, I'm one of the gastroenterologists with the University of Colorado. My clinical expertise is in colon cancer screening, especially in high-risk populations and people with genetic disorders that put them at higher risk to develop colon and other GI cancers. I have no disclosures for my talk today. And I wish I had a lot of time to talk to you today about everything I know about colon cancer. But with this limited time, I'm going to be focusing on when to start screening for colorectal cancer, what are the available screening tests that we have, and how can we improve colorectal cancer screening. It is no news to anyone here that colon cancer is the third most common cancer, both in the United States as well as globally. And it is one of the leading causes of cancer-related deaths, both in men and women. However, over the last several decades, we have been seeing a decline in both the incidence and mortality of colorectal cancer. Part of this is attributed to the risk factors that we have. Some of the risk factors for colon cancer are things that we have no control over, things like old age, being a male, or some medical conditions like diabetes or inflammatory bowel disease, or genetic disorder that put some people at higher risk to develop colon cancer. However, some of these risk factors are things that we can do something about, things like smoking and heavy alcohol use, or obesity. And even the diet that we're eating. We do have data that shows us that the diet that's high in processed meat or red meat does increase our risk to develop colon cancer, while the diet that's high in fiber can actually decrease the risk to develop colon cancer. So it's important that we're all aware of these risk factors to educate our patients on them. And the decline in colorectal cancer mortality is not only because of the improvement in some of these risk factors, but also because of the screening programs that we have been doing. Colonoscopy, for example, there are lots and lots of studies that show that colonoscopy plays a big role in decreasing the incidence and mortality of colorectal cancer. And we do see an inverse relationship between the uptake of screening colonoscopy as well as the decline in this incidence of colon cancer. And this decline in the incidence and mortality has also been more evident around the year of 2001, because it was that year when Medicare expanded the coverage of colonoscopy from people with high risk to include all individuals. And after that year, we do see that decline to be more obvious. But I do want to point out that while we are seeing this decline, we are mainly seeing it in older individuals. But when we look at the younger individuals, younger than the age of 49, we are actually seeing an increase in both the incidence and mortality of colorectal cancer. And that's almost 1 to 2% annual increase since the mid-1990s. When we talk about colon cancer for younger people, we do notice that it tends to happen more in the left colon, rectum, and sigmoid. It tends to be more aggressive, and those younger people are more likely to present with either blood in the rectum or abdominal pain. And our guidelines have changed since 2018 in regards to the age to start screening for colonoscopy. It was the American Cancer Society that was the first society to recommend starting at the age of 45. And that was eventually followed by the National Comprehensive Cancer Network guidelines, the American College of Gastroenterology, as well as the U.S. Preventive Services Task Force. And all of our societies now recommend that all individuals starting at the age of 45 should be screened for colorectal cancer. But how about family history? Because we do know that if someone has a first-degree family member who's had colon cancer, then that person's risk to develop colon cancer is 2 times higher than the rest of the population. And that risk almost doubles if that person has 2 first-degree family members who had it, or if that first-degree family member had it at a young age, younger than the age of 60. Which is why the Multi-Society Task Force, as well as the National Comprehensive Cancer Network, give us guidelines, specific guidelines, to those people with family history of colon cancer. which is beginning colonoscopy at age 40 or 10 years before the earliest diagnosis of colorectal cancer. So if our patient's father had colon cancer at the age of 42, we need to start screening our patient at the age of 32. So it's almost always 10 years younger or at age 40, whichever comes first. But it's not only family history of colon cancer that we care about, because what we know about colon cancers is that the majority of them develop from polyps. This is what we call adenoma to carcinoma pathway, meaning there is a small growth that starts in the colon that continues to grow with time until it turns into cancer. And what we're able to do when we do colonoscopies is identify these polyps and cut them out before they even turn into cancer. So something that's important to ask our patients about is if they have family history of advanced adenomas or these large polyps that were taken out before they even developed cancer. Because we do know that if the patient has a first-degree family member who had an advanced adenoma, then the risk to develop colon cancer is similar as if that first-degree family member had colon cancer. So for those people, we also have to begin colonoscopy at age 40 or 10 years before the earliest diagnosis of colorectal cancer. So now that we know when to start screening, what are the available screening tests for colorectal cancer? We mainly have three buckets or three categories that we use for screening tests. The first one is the visualization tests. The most common one that we all use is the colonoscopy, but there are a couple other tests under that category like flexible sigmoidoscopy or CT colonography that could also be other alternatives. Those visualization tests allow us to see the colon and whether that colon has any polyps or any cancer in it. And if we go back to that adenoma to carcinoma pathway, we do see that this colonoscopy and visualization tests allow us to find the cancer or the precancer stage from polyp to cancer at any part of this diagram. So these are great tests. However, what we know about colonoscopy is that it is an invasive test. It is inconvenient because it requires bowel prep, taking time off from work, having someone drive people home after the procedure. And even though it's a very safe procedure, it does have its risk of complications. And unfortunately, colonoscopy is not a cheap test. It is an expensive test that we need to be aware of, which is why the second category of stool tests come into play, and we need to be familiar with those as well and offer them to our patients. The very first stool test that was discovered in the old days was the fecal occult blood test. This was checking the hemoglobin in the stool, but it was not specific to the human hemoglobin. It was actually affected by the diet or the medications that the patient was taking. So the patient had to modify those before doing the test. And the test at the time required 3 different stool samples to be done. But nowadays, we use more the fecal immunochemical tests, where in 2008, several of our professional societies endorsed this FIT test to replace the fecal occult blood test. What this test does is that it has an antibody that binds to the globin part in the human stool. So it is more specific to the human part itself and not affected by the diet and medications like the fecal occult blood. And it usually requires 1 stool sample to get it done, rather than 3. And in 2014, another stool test was FDA approved, which is the multi-target stool DNA. This test basically checks for specific DNA changes in the stool that could be coming from tumor or precancerous cells, as well as the FIT test. So it combines both tests, the DNA biomarkers, as well as the fecal immunochemical test. So how good are these stool-based screening tests? Well, let's start with the FIT test first. If we talk about how good it is at detecting these large polyps, or what we call advanced adenomas, we do notice that it detects 2 to 3 out of 10 advanced adenomas. But for colon cancer, it has better sensitivity, where it's able to detect almost 7 out of 10 colon cancers. Another number that we care about when we talk about screening tests is the specificity. The higher the specificity, the less false positive results we're getting from that test. And as you see here, FIT test is very specific at 96%, so only 4% are going to be false positive. How about the Cologuard? Well, Cologuard is actually better than FIT at detecting both the advanced adenomas as well as the colorectal cancer. It can detect 9 out of 10 cancers. But because it combines two screening tests, we do see here higher chance for false positives, with almost 10% being false positive. And if we go back to our diagram, the adenoma to carcinoma pathway, we do see that the stool tests are actually good at detecting cancer, but not as good at detecting the polyps or advanced adenomas. However, over the last couple of years, we've had two new stool tests that were approved. The first one is the Cologuard Plus, or the next generation multi-target stool DNA test. This one was FDA approved in October of 2024. And this was based off of the Blue Sea trial, which is a very big trial that they did on over 20,000 people in multiple US sites. The goal here was to improve the specificity of Cologuard test, meaning decrease the false positives, while trying to maintain or increase the sensitivity, meaning catch more advanced adenomas and colon cancers. And that what they found out is that sure enough, this test is actually able to improve the specificity as high as 93%. We're going to be having less false positives with this Cologuard Plus. And it's also better at detecting advanced adenomas as well as colorectal cancer, with better numbers in those two. And the other test that was also FDA approved in May of 2024 is the multi-target stool RNA test, or the ColoSense test. While the Cologuard uses DNA biomarkers that are detecting in the stool, this RNA test is going to be checking for RNA biomarkers in the stool. And similar to Cologuard with combining the FIT with these biomarkers, this test also combined the FIT as well as these RNA biomarkers. And the study for this RNA test was done on over 9,000 people. While we don't have head-to-head data to compare Cologuard Plus with ColoSense, if we look at the numbers from these studies, we do see that ColoSense is also even better at detecting advanced adenomas. That number goes up to 46% here. And it's also very good at detecting colon cancer with 94% sensitivity there. The specificity, though, is a little bit lower at 88%, so there could be a little bit more false positives with this ColoSense test. So going back to our diagram, we do see that these stool-based tests are getting better and better at detecting advanced adenomas or these large precancerous polyps. So now that we've learned about these stool tests, what do we know about blood-based tests? Well, the Septin9 test was the very first test that was approved in the past. At the time, the data showed that its ability to detect cancer was only 48%, meaning less than half of the people with cancer were caught by this blood test. And even when they modified the test and came up with version 2, less than 70% of the cancers were being caught by this, which is why this Septin9 blood test was eventually withdrawn from the market. However, in the last couple years, we have two more tests. One is the Guardant Shield test that was FDA approved in May of 2024. The second one is made by Freenom. It's not FDA approved just yet, but they published the data of that test last year. What these blood tests show is that they look for the presence of specific changes to the DNA that's floating freely in the blood, which is called a cell-free DNA. And the data showed that these tests are able to detect around 80 to 83% of colorectal cancers. However, if we look more deep into the data of these blood tests, we see that their ability to detect stage 1 cancer is only a half. And this is a very important thing to realize because they're able to catch more advanced cancer rather than early cancer. And the reason we care is that the survival of colorectal cancer is very different between the different stages. If we're able to catch colorectal cancer at stage 1, the survival for our patient is as high as 91%. While if we're not catching the cancer until it's at stage 4, the survival is only 16%. The other important thing to note about these blood tests is that their ability to detect advanced adenomas is only 13%. And this number is actually no better than chance, because if we look at the prevalence of advanced adenomas in general population, it is usually 11 to 13%. So if we go back to our adenoma to carcinoma pathway, we see that the blood tests are only able to detect that late stage cancer, but not the early stage cancer or the advanced adenomas. The last thing I do want to mention about these screening tests is that if we order any screening test other than colonoscopy, these are all two-step tests, meaning all of them have to be followed by colonoscopy. Any abnormal screening test definitely has to be followed by colonoscopy. So, what can we do to improve colorectal cancer screening? If we look at the data that we currently have, the up-to-date screening prevalence in the United States is less than 70%. And in Colorado in particular, we're at 63%. And screening is lowest among individuals between the ages of 45 to 49, Asian Americans, people who are newly immigrated to the United States, people who have less than high school education, or the uninsured individuals. And these are big challenges that we have in the United States and in Colorado. And if we're talking about screening for our family members, our friends, this is an easier topic. But the topic here that we're talking about is the screening in a population-based scenario. And what we know about that is that the effectiveness of such a big screening program depends on two main things. One, the test efficacy. How good is that test at detecting cancer as well as preventing cancer, as well as the participation? Because even if the test is good, if we don't have enough people participating in it and doing it, then the whole screening program is not effective. We have already learned about the efficacy of the different screening tests that we have. We do know that the colonoscopy is the most effective one of them, but the stool-based screening tests are getting better and better at that. But what do we know about participation in screening for colorectal cancer? Well, we have a couple clinical trials that were published in the last couple of years. The first one is the Nordic trial, where they looked at two groups of people. One group, they invited them to do colonoscopy by sending people a mailed letter. And the other group, they did no efforts for screening. Of the group that was invited for colonoscopy, only 42% of them actually completed the colonoscopy. And when they looked at the data at the 10 years, yes, there was decrease in the incidence and mortality of colorectal cancer among those who completed the colonoscopy. However, among all the people that were sent the letter, there was no change in mortality. The second big clinical trial that was published last year is the colon prev, which was done on over 57,000 people in Spain. And they looked at screening for colorectal cancer using an invitation with either colonoscopy or a FIT test. And what they found out is that an invitation for colorectal cancer screening using a FIT test is not inferior to colonoscopy in regards to colorectal cancer incidence or mortality. And another randomized clinical trial that was done in Poland randomly assigned people to one of three groups. One group that was offered colonoscopy only. The sequential group was offered colonoscopy with subsequent FIT test. Or the third group was offered a choice between either doing a colonoscopy or a FIT test. And they found that those people who were offered only colonoscopy, their participation rate was only 17.5%, while that participation number was higher in the other two groups. It is still not great, but definitely better than the group that was offered only colonoscopy. And in that study, they also looked at the diagnostic yield for advanced neoplasia, which was actually not different between these three different groups. It was the similar rate. Which is why our guidelines recommend offering a menu of options to our patients. We offer colonoscopy or FIT test or all these other screening tests. Yes, colonoscopy remains the best test to do, but we have already seen that these stool-based screening tests have very good sensitivity for detecting colon cancer. They are less sensitive to detect advanced adenomas or these large precancerous polyps, but the sensitivities for that are getting better and better as we saw in these newer studies. How about the blood-based screening tests? Well, there is at least one randomized controlled trial that shows that the uptake of screening with the blood test is better than the FIT test. Because of course, it's easier for our patients to do a blood test over having to worry about collecting their stool and doing that effort. However, we have already seen that these blood-based screening tests are not good at detecting stage 1 colon cancer. And they're even worse at detecting the advanced adenomas. And we do have a modeling study that showed that if we assume 100% adherence rate with screening, with all the different screening tests, then we're going to see an increase in the incidence and mortality of colorectal cancer in those people who do the blood tests compared to the stool tests or colonoscopy. Therefore, we can say that these blood-based screening tests have poor sensitivity for early-stage colon cancer. They have no role in cancer prevention and should only be offered to those who decline both. And my take-home points today is that we should be starting screening for our patients at age 45 or sooner if there is family history. We talked about the different screening tests, and I want you to know that these stool tests are getting better and better. And in order to have our patients get screened, we need to offer a menu of options, but be careful with offering the blood-based screening tests. Thank you, everyone.
Thank you very much, Dr. Safady, for that great overview and all of that key information. And yes, there's been a lot of interest and questions about blood-based tests and technologies as they're advancing. So yes, we should all be paying attention to the data as they evolve. I'll have Michael bring up his slides. Really excited for him to share about his personal cancer journey and diagnosis. But before he gets started, I did want to just ask one question that came up in the chat from Catherine, if there's any discussion happening to possibly lower the baseline screening age even further to 40.
I mean, there are discussions about that, especially with the rise of early early onset colon cancer. I don't think it's going to happen soon, but there's a lot of research happening about why we are seeing that rise in early onset colon cancer and what can we do about it as a society.
Thank you. All right. Well, Michael, I'll turn it over to you to introduce yourself and share your story. And you're on mute still, Michael.
Yes. Sorry, I couldn't
No
find
problem.
couldn't
There we
find the
go.
unmute button. Sorry about that. Um, so my name is Michael Holtz. I am a 14-year survivor of stage 3B rectal cancer. I have been a cancer advocate actually for longer than I've been a cancer survivor. I went to work for the American Cancer Society in 2002 and worked on on the communications and then the policy side for a long time. And I was diagnosed in 2012. So, and I'll talk more about my diagnosis story, but just to sort of, I've been in this space for a long time, and um, early detection and prevention and policy and research are all issues that are very important to me. But I wanted to start with a level set of just why I keep doing this. I mean, my story is one thing, but the faces that you see on this screen are the reason that I keep doing the work that I do in the cancer advocacy space. The guy on the left side of the screen was my best friend, Ryan Veith. He actually lived in Centennial, Colorado. We met because of our work together at Fight Colorectal Cancer. He was diagnosed with CRC at age 47 and passed away in December of 2024. He was a loving husband, devoted dad to 5 boys, had just gotten to see the birth of his first grandchild when he passed away. And we had plans to do events like this together, and I continue advocating largely in his memory, but also for the other folks on the screen, the folks that you see on the top row, Sarah, Brandon, Zach, Jason, and Yuli are all folks who have passed away from early onset colorectal cancer, and the folks on the bottom, Trevor, Kyle, Ruth, JJ, and Nathan are all in their 30s and 40s who are dealing with stage 4 colorectal cancer. Some folks may know JJ. He's sort of colorectal cancer advocacy famous. He's on like round 200 of chemotherapy after 10 years of treatment. And he's a great guy. I love all of these people. So, but they are the reasons that I keep speaking up and wanting to spread the word about the importance of early detection and prevention. So my cancer story really started in December of 2011. As I said, I worked for the American Cancer Society, and ironically, I was actually at a work meeting at ACS World Headquarters in Atlanta when I first remembered experiencing funky digestive symptoms, feeling like I had to go and nothing would happen, or I couldn't get to the toilet fast enough. I was training for a marathon at the time that I actually ran 3 weeks before my diagnosis. And members of my training group were reading a book about the increase in celiac disease because of industrial farming of wheat and how that was impacting the nutritional value and what that was doing to our guts. And I read that book, and as I was reading the book, I was like, check, 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 like all the symptoms they were talking about I had. So I went gluten free for a couple of months. And then in February of 2012, there was blood in the toilet. And I called my primary care, and he fortunately said, if there's blood in the toilet, you're getting a colonoscopy. As I said, I ran the New Orleans Marathon in March of 2012, which was on March the 4th. I was diagnosed on March 27th, but between that, I had a colonoscopy consult with my gastroenterologist And because of my age, he was seeing a rising increase in irritable bowel disease and celiac, that's 100% what he expected he was going to find when he went into my colon. Um, However, he found a tumor on my rectum, about 3.5 inches long. And ultimately, I was staged as 3B. I underwent 55 days of Xeloda combined with 28 rounds of radiation. If you've never experienced rectal radiation, I highly recommend not ever having to experience that. Um, it is brutally painful and yeah, just you don't want to go there. Um, Lots of blisters. My radiation oncologist talked about getting blisters on my gluteal crease, which is a phrase that still makes me laugh to this day. Because we're talking about the butt crack, and we should just say crack. But that's my opinion. Um, I had surgery to repair that resulted in a full rectal resection, so I have a permanent colostomy and followed up with 12 rounds of Folfox and finished treatment in February of 2013. And I was declared no evidence of disease on May 15th of 2013 and have been no evidence of disease ever since. Um, However, knowing what I know now about life in the colorectal cancer advocacy space, I'm really one of the lucky ones. First line treatment worked for me. And I know a lot of the people that I showed you on that slide, the first slide, um, they're on second, third, fourth, and fifth lines of treatment. So getting to the bottom of all of this is really important to me. Um, After treatment, we like to think and hope that life after cancer means we don't think about cancer anymore, but those side effects don't go away very quickly. I had 7 cavities after treatment, as well as high blood pressure. The steroids from being able to tolerate the Folfox resulted in left ventricular hypertrophy. Basically, the left ventricle of my heart was enlarged. That has now resolved because my blood pressure has been controlled. While I was training for the marathon, I lost 100 pounds um, in a healthy way. I knew I was losing it. I was intentionally losing it. Um, During treatment, I gained every one of those pounds back. And I'll talk about that um, on my next slide about sort of the why and the questions I have about that. My metabolism is slower. I have neuropathy in my feet from the oxaliplatin part of Folfox. I have body temperature issues. Being out in the heat is um, basically, I look like I'm taking a shower if I'm outdoors in the summer heat. I have a permanent colostomy, as I said. I recently was diagnosed with hearing loss because of the nerve damage from oxaliplatin, and my ophthalmologist regularly checks me for vision loss to make sure that my optic nerves haven't been damaged by oxaliplatin. I'm a writer and a content creator, so being able to see and hear are really important to my lifestyle and my longevity. Um, so for folks in the clinic who are listening, I just want to implore you not to dismiss young patients who present with symptoms. Um, the increase, we know from the latest data from the American Cancer Society that colorectal cancer is the deadliest cancer for people under the age of 50. Colorectal cancer is the only one of the 5 leading cancers with an increasing mortality rate. Um, People born between 1990, born after 1990, that should say, have twice the risk of developing colon cancer than those born in 1950. They also have 4 times the risk of developing rectal cancer. And what we're seeing, and what Dr. Safady mentioned a bit in the data, is rectal cancer is really leading this increase. And we don't know why that is. There are lots of suppositions. Dr. Safadi touched on, processed meats and processed foods, and there's probably exposures and microplastics and all the fun stuff that we love to talk about, that are, we're exposed to on a regular basis, that all have to do with that increase. But there isn't definitive research at this point that says, yes, this is what's happening. Um, black women and Black men and women are at 20% higher risk of developing colorectal cancer, and they are 40% higher risk of dying from the disease. So we seriously need to take this issue seriously. Um, in terms of how y'all can support cancer patients and long-term survivors, I would say for oncology teams, please talk about the immediate side effects of treatment as early as possible. I talked about radiation to my rectum. Um, Radiation causes swelling of the rectum, which causes leakage. It would have been lovely to know that that was a normal and expected side effect before I had to waddle onto the table with toilet paper stuck between my cheeks, and, to buy diapers ahead of time. Um, I realize my situation is 14 years ago. So hopefully things have changed a lot. But please talk about those side effects. Be whole patient focused. Um, I mentioned that I gained all of the weight that I had lost before treatment. I was one of the lucky few that didn't get nausea and vomiting from Folfox and cancer treatment. I could only not stand the smell of like cumin and cilantro. Um, and so the nutritionist at my cancer center, who no longer works there, basically said, from a food perspective, eat whatever you can tolerate. Well, if she had known that I was a guy who struggled with my weight my entire life, I would hope we would have made a different recommendation, because it was like giving the keys to the bakery to a fat kid and saying, have at it. Um, I am not abdicating any responsibility for the weight that I gained during my cancer experience, but having someone to talk to on a regular basis, someone who was concerned when my weight jumped 15 pounds between Folfox treatments, would have been beneficial. Um, and then again, be honest about the side effects. I've heard a lot from my fellow survivors that, they were told that, neuropathy caused by oxaliplatin is temporary. I can tell you almost to a person, we have permanent neuropathy from oxaliplatin. Um, and I know we are learning more. It's been years since 22 years since Folfox um, really became standard of care, and we're learning more. Um, but be honest about what those side effects are. And then if you don't offer primary care oncology, or, um, at your clinic, ensure a strong handoff to a patient's primary care provider. I was lucky that, I have a primary care provider who, um, understands my entire medical history. She has done more research about the treatment that I had and the side effects. The reason we caught hearing loss is because she had done research on the long-term side effects of oxaliplatin and said, hey, maybe we should do a hearing test. And then for primary care providers, just kind of, you know, double teaming on that hearing loss thing is understand the possible long lead side effects that your patients might be facing, like hearing loss. I'm a 56-year-old man. I am healthy. I move very well, but with neuropathy in my feet, what is that going to look like in my 70s and my 80s? And we need to be thinking about that. And then for all patients, have survivorship plans. Patients should be given a survivorship plan of some nature when they leave care, so that they have an idea of what to expect or when to ask certain questions, or so that their primary care provider knows when to ask specific questions. Um, One of my dreams actually is a longitudinal study of cancer patients who have been treated with oxaliplatin and other platinum-based chemotherapy treatments. That research doesn't exist because when FOLFOX was first developed, patients didn't necessarily expect to live long past 5 years. Well, that's changed a lot. There are a lot more of us who are survivors, and we need more of that data so that we know what to do with the patients who are still here. Um, and that's what I have. So, Elsa, I'll turn it back to you.
Thank you so much, Michael. Really appreciate you being willing to, yeah, be an advocate and share your story and the stories of others with so many. As we talked about before this started, I mean, I think it's so valuable just to be people who are willing to be open and honest and share these stories and raise awareness. There's so many ways we can raise awareness and make a difference, and that includes in clinic settings, outside of clinic settings, with screening, with prevention, and then with supporting people in survivorship and during treatment. So thank you. Um, Please, everyone, feel free to add other comments and questions in the chat. We do have a few comments coming through. Also thanking you, Michael, and for sharing your story and just about the value of having patients being willing to share those experiences and just being really open and honest. I think, yeah, being really candid can make a big difference. So please add other thoughts in the chat, but I'll start us off with one question is, what is an area that I can ask this to both of you, feel like should be a key priority or consideration, especially in the primary care space to really increase completion of colorectal cancer screening? There's so many reasons why patients are hesitant or have barriers to complete screening. So what is one piece of advice you'd give that could help make a difference in increasing completion?
Um, I think meeting our patients where they're at is going to be important. Having that discussion with them when we see them, understanding that particular patient, what are the barriers that are preventing him or her from doing the screening? Is it the cost of the procedure? Is it the prep of the procedure? Or is it the lack of awareness that colon cancer is the third most common cancer? So I think just trying to clarify what is preventing our patient from proceeding with it and trying to find a way that meets them where they're at might be helpful.
Yeah, I agree with Dr. Safadi. Meeting patients where they're at, understanding what their barriers are, and also just encouraging them to do, if they're not going to do colonoscopy because they don't want to do the prep, because they have hangups about an invasive procedure, then do one of the other non-invasive procedures. The best test that someone will do is the one that they'll do. So get them to do something.
Yes, definitely. And I mean, I think we see with all the clinics we work with is sometimes patients might not be willing to go through a screening after the first conversation. So can be really valuable to just continue to bring that up each time you see them and sending reminders and all those tools so then they can feel empowered to move forward once they are ready. Um, and then I guess what is one piece of advice, Michael? Maybe you can elaborate on that linkage between primary care and oncology and just sharing a little bit more of things that worked well for you or personal barriers you experienced in maybe warm handoffs or communication between oncology and primary care.
Yeah, I think just ensuring that there is a warm handoff. I had a situation where, and I have to say, I have had two primary care physicians since my cancer diagnosis. And my first primary care physician with my last oncologist, which gets complicated. I had three oncologists. It's a whole thing. Um, Third oncologist and did a test or wanted to do a test because my calcium level in my blood system was high, which can be on some level a precursor, a marker for potential recurrence. But my primary care doctor just kept doing watch and wait. And at my last meeting with my oncologist, he sent a note to my primary care doctor and said, do something about this. Basically, like imploring him to like be the primary care doctor and do the thing he's supposed to do. And my doctor looked at me and he said, well, what does that mean? And I said, okay, here's what I know about high blood calcium. And, I said, why don't we do a parathyroid hormone test? Which ultimately we did. And my parathyroid level was high. And I had surgery to remove two of my parathyroid glands. But I sat in this like watch and wait of like, nobody's talking to each other and the patient has to like, okay, this is the thing we need to do. And um while it ultimately was the correct choice, like they should have been on the same page or something. And now I have a new primary care doctor, and as I said, she has looked at the entirety of my medical record. She knows what I've been treated with. She knows what the doses were. So when I meet with her, and I meet her every 3 months because I have high blood pressure, we talk about, whatever is on her radar from a long lead side effects perspective.
Thank you. Yeah, I think communication and being clear on kind of who's doing what can be really valuable. One more question for you, Dr. Safadi, and then I'll open it up to see if anyone wants to come off mute and ask a question. I know you touched a lot on the importance of family history and collecting that. So, are there any tools or best practices you would recommend to make sure that family history is documented and collected both on the patient side and then collected by the healthcare side, and then that information acted upon? Any resources you found that have been really helpful or just best practices in making sure that stays up to date for patients?
Asking that question during the patient encounter is going to be important. And I do it with every one of my GI patients that I see in clinic. Even if the patient is coming in for GERD or something not related to colon cancer, I always ask, do you have a family history of cancer? And in particular colon cancer. So I think during especially our annual visits with primary care doctors, it is always important to ask that question. And then if the patient has a family history, especially in a first degree family member, then we definitely need to do something about it, start screening sooner rather than later. And one thing I do want to point out here is that both guidelines, the ones that I mentioned, that recommend screening for those with family history at an earlier stage, colonoscopy is actually the test that we need to use for screening, especially if the family history is of colon cancer at a young age or two or more first-degree family members. Then colonoscopy should be the test getting done. But if our patient is refusing colonoscopy, any test is better than no test. That would be my advice there. And I do want to point out one more thing here, not related to this, but related to the previous question about the colon cancer in young people. I think what we can do nowadays is make sure we're doing something about the symptoms in these young people. In the past, we used to ignore abdominal pain, blood per rectum in those young individuals, but I feel nowadays we need to take these concerns more seriously. Yes, hemorrhoids continue to be the number one reason for blood in the stool in young people, but even when I find those during my rectal exam, I still proceed with doing colonoscopy. I do not ignore that complaint because even though hemorrhoids are there, there could also be a tumor in that rectum giving us that fresh red blood that the patient is seeing. So please have a very low threshold to proceed with diagnostic colonoscopy for young people with symptoms.
Yes, thank you for bringing up that point.
I
We
was,
did just have, oh, go ahead, Michael.
I was just going to say thank you for saying that, Dr. Safadi. I have been saying that for a long time because a lot of, especially young women, present with hemorrhoids and they get dismissed, often. So to have a low threshold is amazing.
Yes, and I will say from all the survivors that I've met or have shared their story, it's very common that many of them said that their symptoms were ignored for many months, or they just got worse and worse before that they were acted upon and had a colonoscopy or ended up, unfortunately, in the emergency room. We did just have another question come through in the chat that says, are there other cancers related to family history that could put a patient at higher risk for colon cancer?
Well, I mean, I do hereditary colon cancer as well. So the most common hereditary condition in the colon cancer world is Lynch syndrome. And in Lynch syndrome, the two most common cancers are colon and uterine cancer. So, and that's one thing probably to pay attention to is that if the patient has family history of uterine cancer at a young age, ovarian cancer, or maybe colon cancer in a grandparent, then that would raise a red flag that there could be something. Current guidelines do not recommend that we need to screen someone with colonoscopy for a family history of uterine cancer, but it should definitely raise a question mark there if there is a family history of multiple cancers.
Yes, thank you. Okay, we have time for one more question. Does anyone want to come off mute and ask a question rather than putting it in the chat? Going once, going twice, going three times. All right. Well, with that, I'm gonna give Michael and Dr. Safady turn it over to you to see if there's any closing thoughts you want to end with that we haven't already touched on. I'll also put the evaluation link in the chat. And yes, appreciate everyone for joining us today. But Michael and Dr. Safady, are there any final closing thoughts that you want to share?
Just for me, just to say thank you for this opportunity to share my story and hear a patient perspective.
Thank you, Michael, for being here. And the last thing I want to say for every one of you today on this call, I think you're already making a difference by joining such educational lessons to try to be up to date with what's changing in the colon cancer world. So you're already making a difference. And just try to remember that every time you meet with a patient, we can do our best, educate our patients, order the tests, do the workup, and hopefully, the same way we've been seeing that decrease in colon cancer in older adults, hopefully we can all get together to a point where we start seeing the decrease in younger adults as well.
Thank you so much for your time today. Appreciate everyone for being here and would like to echo what Dr. Safady just said. I see so many little things that everyone in our community is doing to make a difference and the real effects it has on people's lives every day. So keep the work up. Happy Colorectal Cancer Awareness Month. And we'll talk to you all soon and share all this information in the follow-up. So thank you all. Have a wonderful rest of your day.
Thank you all. Thank you, Elsa. Thank you, Michael.